Hi, this is Brian Wormers recording a lecture on inflammatory intestinal disorders for medical surgical nursing at the University of Sioux Falls. Some of the things that we'll be talking about today are going to be appendicitis, peritonitis, gastroenteritis, IBD, diverticular disease, celiac disease, and infections with parasitic or helminthic. So an appendicitis is inflammation of the little hangy downy thingy, your appendix, off of your intestine. And so where we're going to see this most oftentimes is that you're going to get pain right here at McBurney's point, which is in the right lower quadrant, and you're going to see more common of rebound tenderness. So you push on it, it's all right. When you let go of it, then that's what hurts, and that's related to the zoas. But you don't have to necessarily know that one, why it does it, but just realize right lower quadrant, rebound tenderness, McBurney's point, all those things are big key factors of this one. Patients might have perforation of this, so if they have all those signs and symptoms and all of a sudden they're remarkably better, it might be a sign that this popped and ruptured, and so they will state that they feel better until peritonitis kicks in, and then they get really septic. So, history and physical is probably one of the biggest ways to diagnose this. But then you might check it with an ultrasound to see if the appendix is there and if it's inflamed or irritated at all. And you can do the same thing with the CT. Treatment is surgical in nature. It really is not an emergent type of situation, but it should be done sooner rather than later. Oftentimes we can do this laparoscopically, and that's kind of a nice way. Prior to that, we're going to probably make them NPO, start them on some IV fluids, put them in a position of comfort, which is often semi-Fowler's. Give them pain meds as needed. We do not want to give any laxatives or stimulants because that could lead into perforating that appendix. I'm not going to do heat because heat expands things and that might cause more inflammation and cause it to pop. And then oftentimes we'll give some antibiotics. And so ciproflagyl is one of those big things. If they're fairly stable, what we might do is treat them with cipro and flagyl for an extended period of time, like 6 weeks. The body will encapsulate that, and then you can go in on the same day type of situation and do surgery then. And then it's an outpatient basis then. If we have to be more aggressive, and if this is ruptured and we need to do a surgery sooner rather than later, then oftentimes that they get kind of sick from that because you're moving that fecal material around in the peritonitis or into the peritoneum, and they get peritonitis, and they are sick for a couple of days usually. So peritonitis, like I said, this is life-threatening, and so if you get stuff in the stomach contents that you shouldn't have there, so whether that's bowel and fecal material or hydrochloric acid or whatever, but this is an inflammation and irritation of the visceral peritoneum. Often it is bacterial in nature, and so we'll often treat it with some antibiotics. How it looks is rigid and board-like. If you ever hear those terms, know that, think about peritonitis with this. Think that this is really, really bad if they get a really rigid, stiff, board-like abdomen. They might have pain, distended abdomen, high fevers, tachycardia, dehydration, hiccups, and that's because of the vagus nerve. Compromised respiratory status, nausea, and vomiting. They are at extreme risk for sepsis with this one, and so it's quite common, so we are going to be treating it very aggressively. So physical findings depend on how sick they are, how soon this has started, how long it's been going on, but they usually do not look well. They look acutely sick with this one. They'll often lay still, knees are flexed, they'll have signs of pain, and the WBCs will be elevated. Treatment-wise, we're going to do IV fluids, antibiotics, monitor them for I's and O's, daily weights, nasogastric, NPO, especially if they need surgery, supplemental oxygen as needed, pain management as needed. And then if we're doing surgery, we're really trying to control any contamination that might be in there, removing any foreign material. Might even putting some drains so that they can collect the fluid afterwards. But then afterwards, semi-Fowler's position, wound care, keeping them clean and dry and intact in those kind of situations. Gastroenteritis, so this is inflammation of the mucous membrane of the stomach and the intestinal tract, usually self-limited. Bacterial form can be Campylobacter, Shigella, E. coli, Salmonella, a whole host of things. Norwalk virus is one of the more common ones I've seen around here for a viral gastroenteritis, but you can start talking about C. diff or other things like that. So ask about any recent travel, see if they've been sick or exposed to anything new. Do they have muscle aches, headaches, malaise with this one? Are they dehydrated? Interventions are often supportive in nature, so treatment with fluid and replace that. Supportive care with nutrition. If it's bacterial and it's all right to treat them, usually we might not treat with E. coli, but we'll treat with antibiotics. Sometimes we won't do that. Oftentimes what we will do is just do supportive care and let them eliminate the organism. And then of course good skin care, as they can get breakdown on the skin. So chronic inflammatory bowel disease is broken down in two different sections. So ulcerative colitis is one type and Crohn's disease is another one. So with ulcerative colitis, it's of your colon. I know that you're surprised by that. And it can go throughout the entire colon, but it does not go to other sections of your GI system. How does it present? Loose stools, often mucousy. These patients are usually having some malabsorption of nutrients and thickening of that colon wall. They can put them at higher risk for colon cancer, especially if they got a family history of colon cancer, or you see family physical assessment, so they might have fever, tenderness, an unpleasant and urgent sensation to defecate, colicky pain that gets better with defecation, and they might have some malnutrition with this. So psychosocial assessment, so this is very disruptive to their life, can be very stressful, so make sure that we're supporting them appropriately. Laboratory assessments, we're looking for signs and symptoms of infection or inflammation, so that's why we're doing H&H, WBCs, RBCs, ESRs, and electrolytes. If it gets bad enough, they can have bleeding issues, and hence why we're doing the H&H. Other diagnostic tests, so colonoscopy is usually definitive for your UC, and you can see the irritation, swelling, like in this image. Other treatment modalities are usually used to try and calm the body down. So aminosalicylates, and this can be given like in a rectal foam. Steroids, immunomodulators, try and calm that body down like Remicade or Humira. Antidiarrheal meds used with excessive caution, because if you slow everything down, you can cause a toxic megacolon where everything gets big and actually can rupture, and that causes peritonitis, and that's bad. Nutritional therapy, so if they're NPO, then we've got to feed them some other way, whether that's with like TPN or nasal tubes or some kind of situation with that. Usually NPO is going to limit, and you won't be able to put down a feeding tube and stuff like that because it's going to go into the colon. So TPN is probably one of your better bets, although there's a lot of IV fluids with sugar. And then when they can start eating, we're going to do low residual diets and let them clear that off, and then support them with emotional and physical rest. Now the other form of this would be Crohn's disease, and this can be mouth to anus, and so that's a big key with this one. Often with this one you can get fistulas, which is a big red flag for you, but you get thickening of that bowel wall with strictures, ulcerations, and then you can kind of see this cobblestoning effect. Both you'll get some malabsorption, but probably more so in Crohn's disease, because it can go in the small intestine, and that's where most of your absorbing of nutrients and vitamins occur. Crohn's disease is also notorious for having these wonderful little breaks and stomas, and so they can get fistulas. And so I saw, one patient that I had, he'd get fistulas in between his intestines and his bladder, so he kept getting UTIs. And so I've seen it, go out through the skin, I've seen it go from inside their bodies, from, like I said, one section to another, like the bowel into the bladder. But realize that they get these fistulas, and that can be concerning. Drug therapy, very similar to UC. We do have to be careful with those fistulas, though. Might have to be put on antibiotics related to some of the leakage from that. Honestly, we usually don't have to do surgery to fix these fistulas, and that's kind of nice, but once we start calming the body down, usually a body will fix these fistulas. Supporting care, fluid, electrolytes, skin care, all those things are very important, just like it is with all forms of IBD. And surgical management if we absolutely have to. The way that this is different than colitis is that, no colon, no colitis. With this can travel through the whole GI system. And so if we start cutting, and then it might end up into more and more and more cutting. And so that's not great. If we can avoid that, we shouldn't be doing surgery if possible. Diverticular disease, so what we see on the intestine are these little outpouchings, and you can see that very well right here. And most of the time, these are fine. A lot of the population has this, never knows about it, and never causes any complications. Now, if it starts causing complications, then we usually have to do something about it. If they start getting seeds or small particulate matter in there, that causes an obstruction, that causes irritation and swelling. That can cause, this to rupture and then start leaking bowel contents into your peritoneum, and that's not good. But other signs and symptoms: nausea, vomiting, fever, chills, tachycardia, gas, and then watch for that bowel obstruction, peritonitis and abdominal distension related to that. Diagnostic-wise, looking for WBC elevation, decreased H&H from bleeding, and then we can check this on some more radiological findings. Helping out, so we want to provide good nutrition to them, but we want to try to avoid seeds, corn, popcorn, things that might get stuck in that little outpouching. Bowel rest is always important with this, and hydrating them up with IV fluids, if not TPN. Moving on, anticholinergics, trying to calm that body down, analgesics, trying to cover any of the pain, NPO, so we don't make things worse. We don't want to do laxatives or edema, because that can cause false stimulation of the GI tract, and that can lead into complications. And so we can talk about these other things too, abscesses, fistulas, obstructions, depending on where this is all at. So, treatment-wise, we can remove a section of bowel if we absolutely have to, but we'd prefer not to. Celiac disease, this is autoimmune disease of the small intestine related to gluten. And so people will have some anorexia, diarrhea, constipation, fatty stools, abdominal pain, and bloating, as well as some weight loss with this. Now, why do they get the weight loss? Well, if they have a reaction to this is all swollen up, full of mucosis, and you're not getting enough reabsorbed into that intestine. Diagnostic-wise, so we can test for antibodies to celiac. Otherwise, we could put them on a gluten-free diet, and if they get better, then that's maybe what it was. So if we do the blood test, though, make sure that they do not take that out of their diet. We actually almost want to increase this and check for the antibodies. If you completely take this out, this might become a false negative, and that we don't want that. So, management afterwards, gluten-free diet. I know it's going to shock you all, but if we have the gluten out of the system, then we don't have the reaction to the gluten. Alright, last one can be different worms. I'll let you take a look at some of these videos yourself, like there, and you can kind of see it. But these are fecal-oral transmitted. You get, these worms will steal nutrition from their hosts, and so you might have signs and symptoms of weight loss, but then probably diarrhea, cramping, fatigue. You might even say that they've seen these little worms in their stools before, and so when they void, you might see this. So diagnostic-wise, we'll probably do a sample for this, to see if we can catch anything, so to speak, and go from there. So if it's an amoebic, then of course we give the anti-amoebic drugs. If it's bacterial, we do antibacterial. But for these other ones, oftentimes we're given special medications to kill these little worms, like the pinworms or tapeworms. Alright, and that concludes this lecture. If you have any questions, please reach out and contact me.